Good morning. I am going to discuss about the assessment in off-pump myocardial revascularization. So I am going to discuss briefly about the risk factors, mortality, and mainly the TE aspects of myocardial revascularization, what all TE assessment you need intra-op, pre-grafting and post-grafting. When we look at the history, in 1710 till the 1935, that was the era where mainly the observational treatment plan were maintained, and in that time Caleb Hilary Perry discovered the relation between angina and coronary ossification. In 1910, it was the first time where the experimental aortocoronary bypass with preserved coronary artery was done in the animals, in dog. After that, from 1935 to 1955, that was the time when the indirect myocardial revascularization era started. In that, Arthur Weinberg reported the first IM implant directly into the myocardium. From 1956 to the 1966, that was the era where the early myocardial revascularization era started, where William Langmuir initially started the grafting of internal memory artery, the coronary vessel, and in 1964 Jarrett and D. Becke he first successfully used the saphenous venous graft for the bypass grafting. From then onwards, 1970 onwards, that was the time of the modern era of revascularization, where Ren Favaloro he used the double internal memory artery graft, that is both Lima and Rima, or in combination with saphenous venous graft, that what we use nowadays. And from 1976 to 1986, Floyd Loop he reported the survival benefit of internal memory artery to LAD, and after that so many advances has happened into the myocardial revascularization. When we look at the indication of coronary artery bypass grafting, where which patient require the CABG. So in patients with more than 50% stenosis of left main proximal to the infarct related lesion, especially area if the area in jeopardized is small and the overall LV function is not severely impaired. Also in the patient where the long and calcified arteries and the arteries are angulated and the targeted lesions are very high risk for the PCI, or the chances of PCI failure are high. Lesions in area other than the infarct artery, unless they appear to be flow limiting in patient with hemodynamic instability or ongoing symptoms. Also, if the lesions are TIMI flow grade 3 in patient with left main or triple vessel disease, where the benefit of CABG or CABG revascularization are superior. Also in the chronic total occlusion, patient who requires the emergency CABG are those who have the high grade left main or triple vessel disease with clinical or hemodynamic instability, and after successful or unsuccessful PCI, preferably with IBP or Impella support, or in those patients in whom the PCI are failed or unstable PCI results in ongoing ischemia along with the IBP and Impella support. Now this is the Euro score where we discuss about the risk factor and mortality. If we see the risk factor, like especially the previous cardiac surgery, active endocarditis and critical preoperative state like in multiple comorbidities, you see the risk factor, the score is 3. Also patient who have the EF less than 30% and the patient who are undergoing CABG along with the post myocardial post infarct septal rupture, they have the higher mortality risk. When we see the Euro score, if the total of the Euro score is more than equal to 6, then the patient becomes the high risk for morbidity and mortality. Along with these risk factors, there are also some of the surgical challenges, technical challenges which presents in day-to-day practice, like sometimes the harvesting of the graft is also very difficult, like, and also the distal supply of the artery are very much calcified, so that patient require the endarterectomy. That itself also increases the morbidity and mortality. Now mainly I will discuss about the TE aspect that will be helpful in intra for the pre-grafting and post-grafting assessment. What we see in TE, we address is the critical issues. Systemic examination with the help of TE, we depending upon the urgency, we do the systemic examination. TE examination we do thoroughly also from the fundamental point of view. Severity assessment, that again depends upon the functions of left ventricle. If the left ventricle function or ejection fraction is low, the severity is high. Study, sometimes we use the TE for the study result recording, and also that recording we discuss with the surgeon and plan of that particular vascularization grafting. Comparative results to preoperative data, we also do the TE for the examination under continuous quality improvement process and equipment maintained and updated. When we look at the functions of ventricle, mainly the left ventricle, we assess the systolic function and diastolic function. In systolic function, we again assess the global and regional function. Now we will go individually what all parameters we see when we look at the LV systolic function. First of all is the load dependent. Load dependent means the function of LV which depends upon the preload and afterload. So in that the cardiac, we see the cardiac output, fractional shortening, fractional area change and estimation of ejection fraction. In load independent, where there is no role of preload and afterload, it is the systolic index of contractility and strain pattern. So in cardiac output, what is the cardiac output? It is nothing but the stroke volume and heart rate. Now how we will see the stroke volume? It is nothing but the cross sectional area and VTI. Now in esophageal echocardiography, we make the transgastric long axis view, while this is the LA, LV and this is the outflow. We measure the LVOT diameter here, and also we make the ultrasound beam parallel to the LVOT area. So we will get the graph like this, and here we measure the VTI. So when we see the LVOT diameter and we go for the cross sectional area, we measure the stroke volume with the help of cross sectional area, what we get the LVOT diameter and VTI from these results. But the problem with this cardiac output measurement is that we measure the cardiac output in a single cardiac cycle. Another problem here is any error in the measurement of LVOT diameter will be multiplied and the error becomes double. And the third problem with the cardiac output measurement is that we assume that the flow into the LVOT, it is the laminar, but any of the problem with the aortic valve, the flow become turbulent. In that case, the measurement will be difficult, or to get the VTI will be difficult. Another measurement of global ventricular function is the fractional shortening. Fractional shortening, for the fractional shortening measurement, what we need is the transgastric mid-papillary view. We measure the left ventricular internal diameter in diastole and left ventricular internal diameter in systole, and we divide it by the left ventricular internal diameter in diastole. So what we get the fractional strain, anything more than equal to 30%, it is normal. Another important parameter is the fractional area change. It is nothing, again for that we need transgastric mid-papillary view. We measure we delineate the internal diameter of the myocardium in the diastole and internal diameter in the systole. We subtract that area and we divide it by the left ventricular and diastolic area, multiply by 100, we get the fractional area change. Now again the problem here is any area what we demark, if it is the regional motional abnormality, it outside of this area, then the fractional area change will be overestimated, and the vice versa. If the regional wall motion area is under the myocard, this delineated line, then the fractional area change will be underestimated. Another important parameter is the ejection fraction. Nowadays we most commonly use the modified Simpson method, and it is most commonly recommended by the American Society of Echocardiography. In that we uses the method of disc. What we do here, each disc here represent that particular area, so the importance and so the efficacy of the measurement will be high. In that, what we need is the mid-esophageal 4-chamber view or mid-esophageal 2-chamber view. Again, in this, the problem is sometimes the foreshortening of the LV causes a problem for the measurement of EF, and presence of trabeculation again gives the false results. Another method apart from modified Simpson method is the Tichold's method, where it is nothing but what we measure the LV end diastolic volume minus LV end systolic volume divided by LV end diastolic volume. By that method also you will get the ejection fraction. In that you need to go for the transgastric mid papillary view in the presence of M mode. Another good parameter is the systolic index of contractility. It is nothing but the dP by dt. So what is dP by dt? It is nothing but the maximum rate of pressure increase during isovolumetric phase of ventricular systole. So what you do for that, this measurement you need to have some sort of mitral regurgitation. What you do, just give the in mid-esophageal 4-chamber or 2-chamber view, you apply the color continuous wave Doppler and you will get the jet. So in jet, what you do during the isovolumetric phase from 1 to 3 millisecond, you measure the velocity. That velocity you use by using the Bernoulli equation, you get that velocity get converted into pressure. So if the dP by dt, if it is more than 1200 millimeter of mercury per second, or the time, that is change of time, it is less than equal to 27 millisecond, then it is the normal. But if that pressure or change in the pressure is less than 1000 or the time is higher, that is approximately more than 32 millisecond, then it is abnormal. That suggests the LV dysfunction. Another important tool is the strain pattern. Now for the strain, what is strain? It is this dimension length index, which represents the percentage change of length from a resting state to one achieved following the application of stress. Now what you do in strain, you require the mid-esophageal 4-chamber view, and that you need to apply a ultrasound beam parallel to the interventricular septum. So that will give the something called as longitudinal strain, circumferential strain and radial strain. So how you calculate the strain L? What is L? L is the state of contraction and L0 is the contraction what you get at the resting stage. You divide it by the L0. You get the strain rate by the same when you divide it by the change of time with respect to the strain. Now important thing to see in a strain is that when myocardium shortens, strain becomes negative. So this is the same thing happens when we calculate the circumferential and longitudinal strain. So we get the strain in the negative value. While the myocardium lengthens, strain becomes positive. This is exactly what happens with the radial strain. Now important thing in strain is that strain, it doesn't depends upon any of the loading condition and it doesn't require any independent parameter. So this is good parameter itself, but the problem is the angulation what you get into for the strain measurement, it is mainly the angle dependent. So to get this strain into transesophageal echocardiography is sometimes difficult. So to overcome that, we need the speckle tracking. Now what is speckle? It is the consistent grayscale tone that will be contributed to the pixel. Now for the speckle tracking, you need to have a specialized software and your image quality should be good enough, or the spatial resolution should be good enough so that the frame rate of the cine loop becomes your prime or fundamental need for the measurement of speckle tracking. So for the longitudinal strain, what you require is the mid-esophageal 4-chamber or 2-chamber view. For this circumferential strain, you require the transgastric mid-papillary view, and also for the peak radial strain, you require the mid-esophageal transgastric view. Now what you need to do, you need to apply the some certain points which is already present in the software. You apply that point and expart that point and delineate the myocardial line, and you take the picture or the loop, cine loop of that particular image. Similarly, what you do in the circumferential strain, you apply the 3-point software here. You adjust the myocardial border according to the software, and you apply the same cine loop into the software. You will get the continuous peak longitudinal strain and circumferential strain. Now this is very important because this is the very sensitive parameter when we see the systolic function of the left ventricle as compared to the ejection fraction. What is the requirement of speckle tracking? Your delineation should be good enough. It should not contain any error into the delineation will give the false result. Another important thing here is that you can see the circumferential and longitudinal strain, the value is in negative, but this is the arbitrary number. Where any value more than any value, if the number is high, the contractility is good and the function is good. Another important thing what you see in the left ventricular function is the diastolic function. You see in diastolic function the transmitral inflow velocity, pulmonary venous flow and mitral annulus tissue Doppler imaging. Color mode, M mode propagation velocity is very lessly we use nowadays, but these three important things what we daily do in our day-to-day practice. What we see in the transmitral inflow velocity, what you need is the pulse wave Doppler across the mitral valve. You get this picture into the mid-esophageal 4-chamber or 2-chamber view. You will get the particular waveform, that is the one you see here, it is the E wave and one here is the A wave. What is E wave? E wave is the early phase of diastole and A is mainly corresponds to the atrial contraction. In normal patient, E is usually more than A. But what happens into the delayed diastolic dysfunction is E wave becomes opposite to that A wave, that is E wave is negative of or less than A wave. Why? This is mainly because of here the contraction of the atrial contraction takes more contribution for the maintenance of cardiac output. Another loop what you see here is the pseudo normalization of the loop. Here you see the E and A wave are usually the normal, or E wave is slightly more than the A wave. But the catch point here is the deceleration time. The deceleration time is prolonged in the case of diastolic dysfunction. In restrictive phase of diastolic dysfunction, you see the E wave is much higher than the A wave, approximately more than 3 times the A wave. By that way you can see the diastolic dysfunction. Another important tool is the pulmonary venous flow. For the pulmonary venous flow, you need to get a LA appendage view. You slightly rightward rotate the transesophageal echocardiography probe and you will get the pulmonary wave. This is the right upper pulmonary wave vein. So what you need to do, you need to apply the pulse wave Doppler here across the pulmonary, across the ultrasound beam, and you will get the particular wave here, the S wave and D wave. What is S wave? It is the systolic forward flow you see in the systole, and D is the early forward diastolic flow. And here the AR is nothing but the atrial reverse flow. Mainly you will see in the atrial contraction, and you also measure the AR duration. Now what is important is pulmonary venous flow is the wave of S and D wave. Normally S is more than the D wave. But what happens when there is a restrictive physiology occurs, this S becomes negative and S becomes less than the D wave, and the amplitude or the velocity of A wave or AR increases and the duration of AR decreases. This mainly suggests when the left ventricular end diastolic pressure increases, the pressure into the LA increases and hence your amplitude or the velocity of AR increases. Another important tool is the mitral annulus tissue Doppler, where you use the tissue Doppler and you get the pulse wave Doppler along the lateral annulus of the mitral valve. Why we use the lateral annulus? Because it corresponds to the most free wall of the LV. When you apply the pulse wave Doppler, you get this characteristic E prime and A prime. Now what is E prime? It is the positive signal in early diastole, and A prime is the positive signal in the late diastole. The important thing is in E prime, if the E prime velocity is less than 8, that means there is a diastolic dysfunction. Now one important ratio, that is E by E prime. What is E by E prime? The E, what you get E wave into the transmitral flow, and E prime, that is you get into the tissue Doppler. The ratio is supposed to be the more sensitive marker for the LV diastolic dysfunction. If the E by E prime ratio is less than 8, it is the normal LV function. If the E by E prime ratio is more than 15, then LA pressure will be more than 15. But if the any value is intermediate of these two, that is 8 and 15, you need to assess the another parameter like AR or another like S wave or ND wave. These are the grades of diastolic dysfunction. This is the normal what I discussed, E and E is more than A, but when this is reverses, this is the grade 1, and when the E is more than 3 times of A wave, that is the grade 3 diastolic dysfunction. This is already discussed. E by E prime, it is more than 15, it suggests the LA pressure is high and there is a grade 3 diastolic dysfunction. Same thing with pulmonary vein Doppler. What you see here is the wave here, there is a prolongation of AR, that is this atrial contraction, there is a increase into the pressure of the atria that corresponds to the retrograde flow of the retrograde flow into the pulmonary vein. That suggests the increase into the amplitude and velocity of AR, and the duration also decreases. Now, when we go for the regional wall motion abnormalities, that what we see nowadays in our day-to-day practice intraoperatively, you need to have a good vision of the bull's eye nomenclature, that is 17 scale model. In a 4-chamber mid-esophageal 4-chamber view, the what you see the region here, it is the lateral wall, basal, mid and apical. This is the septal wall. This is basal, mid and apical. When you make the multiplane angle to the 90 degree, you will get the 2-chamber view. In that case, this part becomes the anterior most and this part becomes the inferior most. When you turn the multiplane angle to 120 degree, this part becomes the anteroseptal and this part becomes the posterior. When you further advance the probe, you get the mid-esophageal transgastric mid-papillary view. In that case, this is the septal part, this is the inferior most part, this is the lateral part, and this is the anterior part. When you withdraw the probe slightly, you will get the mid-papillary, you will get the mitral basal view. Well, you see here the anterior, this is the septal, this is the lateral, and this is the posterior part. When we see the coronary supply of the coronaries, the one you see here in the green part, it is the left coronary circumflex, there is the LCX territory. This is actually the transthoracic view. You will see the RCA territory in transesophageal echocardiography here, somewhere here in the posteriorly, and LAD territory anteriorly. So this delineates the by looking at the territory or the involvement of that particular segment, you come to know that which part of the artery is involved. Now briefly we discuss about the RV function. Now why we need RV function? The involvement of RV function because of the abnormal or supply of the coronary artery is very rare, but sometimes regional functional impairment often with occlusion occurs with the occlusion of RCA or its acute marginal branches. Sometimes the RV free wall also supplied by the coronal branch of LAD, so sometimes the LAD territory or LAD infarction also lead to some sort of RV dysfunction. Regional wall motion abnormality may be due to coronary air or atheromatous embolization during grafting, and some apart from RV dysfunction, you need to look for the signs of other signs of infarction like RA enlargement, RV dilatation, TR or paradoxical ventricular septal motion. Now to assess the RV function, there are certain quantitative assessment similar to what we see into the LV function is the fractional area change, which is nothing but the end diastolic area minus end systolic area divided by end diastolic area multiplied by 100. Anything between 32 to 60% is the normal, and less than 80% suggests the severe RV dysfunction. The catch point here, you should not include the trabeculation and moderator band. Another method is the ejection fraction by modified Simpson's method, and the normal value is less than is the 45 to 65%. Now the problem in the quantitative assessment, especially into RV, is the anatomical variations present into the RV. because of the trabeculations, because of the moderator band. So you need to go with the multiple images or multiple view of the TE of RV. So in that case you need, this is the mid-esophageal 4-chamber view. Sometimes you need a RV inflow outflow view. Sometimes you need a transgastric RV inflow view. So you need to look for all these views so for the proper assessment of the RV function. TAPSE is another good tool for the measurement of RV dysfunction. Now to get the TAPSE into the transesophageal echocardiography, sometimes difficult to get that view, but you can get the transgastric RV inflow view, and in that you get the TAPSE. In TAPSE, what you need to do is you have to align the ultrasound beam along the free wall of the RV where you cut across the tricuspid valve annulus. In that case you will get the normal value of 15 to 20 if the RV function is normal, but if the TAPSE is less than 8, it suggests the RV dysfunction. So in that case you need to apply the M mode. In M mode you measure the TAPSE. Another important tool is the myocardial performance index. So MPI is nothing but, which is also called as TIE index, is a composite index of both systolic and diastolic functions. Again you will get this myocardial perfusion index into the transgastric RV inflow view, where you apply the tissue Doppler and pulse wave Doppler, and you see the particular wave of the RV. What you need to do is you have to subtract the TC. What is TC? Nothing but the tricuspid closure of the opening time divided by the ejection time of RV, and divide by minus the ejection time of RV, and with that you have to divide it by the ejection time. You will get the normal value of 0.2 to 0.4. Any value more than 0.5, it is a predictive of hemodynamic instability and mortality. This myocardial perfusion index is very sensitive for the assessment of RV because it is independent of the heart rate, preload and afterload. So in summary, we have to do a thorough perioperative assessment with the help of transesophageal echocardiography, both pre-op, intra-op and post-op, for the regional wall motion abnormality, especially in the off-pump myocardial revascularization. Here the transesophageal echocardiography, it helps in intra-op assessment of RWMA, both pre-grafting and post-grafting, and the evaluation for the proper attachment or any anastomotic issues with the post-grafting. You can come to know the regional wall territory motion abnormalities. Also this T is very helpful in decision making in inotropes and also for the management of the vasopressors. In LV, global LV dysfunction or global LV hypokinesia, you need to address the inotropes, especially in terms of adrenaline. In that case, T becomes very helpful for the assessment of LV function. Thank you.